about May of 2002. And I'm a family physician, and I practiced in the inner city of Pittsburgh for 15 years. And I was looking after a young lady who was about 19 years old, who brought in her son, who was about 8 months old, for a checkup. And he was crying, and I hadn't even touched him yet, of course, but I mean, he was very upset. And she goes, "Don't worry, I've got something that will calm him down." And she pulled out a baby bottle, and you can guess what was in it. It was Pepsi. Not only that, the little logo on the baby bottle was also Pepsi. And that, of course, for those of you who are familiar with it, that was the Munchkin Baby Bottle Company that received some sponsorship from drinks companies and went in that direction for a while. So that triggered my interest. 2 years later, I was asked to start a pediatric obesity center from scratch with no plans, no idea how to do it, basically. So we went in every single possible direction, waged a complete war on pediatric obesity. And some of that is what I'm going to share with you today. So I have no financial disclosures. This statement comes from the American Beverage Association from February 29th, 2012. And it actually is in response to the CDC brief, which is in your folder there as well. Essentially, it says our industry provides consumers with more choices, smaller portions, and fewer calories than ever before. Development of more low and no-calorie beverages has helped drive a 23% reduction in the average calories per serving. So a little bit deceptive there. And while the beverage calories continued to decline during that time, obesity rates went up. This data from the CDC makes two things clear. Beverages do not uniquely contribute to obesity, and they are not the leading source of added sugar calories in the diet of American children and adolescents. Needless to say, I disagree with that. There is many types of evidence. Dr. Ludwig already shared with you some of those, and I won't go into the mechanistic details to the same extent that he did. There are trends, there are mechanisms, there's observational studies, and then there are interventions. And we can discuss some of these with respect to children. So in terms of consumption trends, yes, children and adults are consuming more sweetened beverages than they have in recent years, even though sweet beverage consumption, especially soda pop, has stabilized over the last few years. And that previous graph, as you can tell, looks pretty similar to the trends in obesity that we see over the same time period. Consumption trends by age are not too surprising. You see that primarily sweetened beverages are consumed by children and young adults, and then sweet beverage consumption tends to taper off after about age 40. The most recent data indicates that about 10% of all calories consumed by children are in the form of sweet beverages, even higher for adolescents, and I think Dr. Benjamin's going to address that. The mechanisms Dr. Ludwig already spoke to you about: poor self-regulation of energy intake in liquid form. The way I actually phrase this to patients is in the following way. Let's say you were really hungry and I gave you a glass of water to drink. Not your first choice if you're really hungry, of course. And as an alternative, I gave you a soda pop, a 12-ounce can, for example. You would probably be just as hungry as you were with the water. However, if instead of the soda pop, I gave you something not so great, a cookie, I think you can get about a cookie and a half in there, you'd probably feel a little bit more full and you'd consume a little less later on. So the compensation or the adjustment that takes place after liquid intake is not the same as it is with solids. Sweet beverages may induce hunger. Sweet beverages are associated with higher overall energy intake. One phenomenon I think that's pretty obvious is that when you're drinking sweet beverages, such as soda pop, you're probably not eating as well in the first place because they're associated with unhealthier foods that are high in sugar in general, high in fat and sugar. Observational studies Dr. Ludwig already pointed to. There is a strong positive association between sweet beverage intake and adiposity or fatness, whether they're cross-sectional or longitudinal. Most randomized trial evidence also supports that. As Dr. Ludwig said, some of the weaker evidence has been funded by industry. Meta-analysis has been conducted recently, and this is an important point. How much of an impact does it really have? If this was a trivial impact, nobody would really care. So essentially, you increase your BMI Z-score as a child by 0.08 for every single can of soda pop consumed per day. That translates into a 14-year-old boy who's, let's say, about 5'5" tall and weighs 140 pounds and isn't drinking any soda pop a day, weighing about 143 pounds if he drank one can of soda pop a day over a variable time period. That's 6 months to a year or so. So that is a significant difference because the next year he may gain additional weight or may increase his consumption significantly. The best estimate of the total amount of effect, or the percentage to which sugar-sweetened beverages contribute to obesity in our society, is about 22% of the increase in weight that's taken place. That doesn't mean that 22% of one's body weight is determined by sugar-sweetened beverages. It refers to how much of the increase in obesity rates are accounted for by this one behavior, and that's a significant portion. So the other effects, I think, are pretty obvious to many people who've been involved in this field. The risk of diabetes is significantly higher among people who consume a lot of sugar-sweetened beverages, primarily mediated through obesity. Bone and mineral density in girls, probably mediated by the fact that girls who consume a lot of sugar-sweetened beverages are not taking in much calcium. Oral health, of course, is a major issue with any sweet drink. And it's amazing to think of how much caffeine adolescents in particular consume when they drink certain types of sugar-sweetened beverages. So back in Pittsburgh, I had a 15-year-old boy who drank 2 2-liter bottles of Mountain Dew every day and played video games all night, probably because he couldn't sleep. So you know, don't underestimate. It's true that a lot of us are coffee drinkers, and the average serving of coffee has significantly more caffeine than the average serving of soda pop. When we were talking about these volumes, especially with young children, that is a significant disruptive effect on sleep. So what do we do about all this? Sometimes it may seem hopeless, so I started this journey 10 years ago. And I was heartened by this statement from the Institute of Medicine, a report on childhood obesity in 2005. It says, knowing that it's impossible to produce an optimal solution to the problem of childhood obesity a priori, we more appropriately adopt surveillance, trial, measurement, error, success, alteration, and dissemination as our course to be embarked upon immediately. Given that the health of today's children and future generations is at stake, we must proceed with all due urgency and vigor. Essentially what it's saying is we can't wait for the optimal solution to this problem. We must try many different avenues before we can find what actually works. And there's nothing wrong with proceeding many different directions. So these are some of the directions I tried, some more successful than others. So in 2006, I wrote a popular book for parents that did very well, still does very well. And it was my sort of advice to parents who were coping with children with childhood obesity. And a couple of months after it came out, a woman wrote to me from the Washington, D.C. area and said, I love my book. I love your book. In fact, I'm going to get my son's personal trainer to read it. And I said, your son has a personal trainer? I don't. And so out of curiosity, I asked her who she was. She was the district attorney for Fairfax County, Virginia. And her husband was, I think, a cardiologist or a cardiothoracic surgeon. I said, you're not the kind of people I think that are in the greatest need. And of course, this kid she was talking about was barely overweight as well. So how do you reach the populations that are at greatest need? Well, Evelyn Whitlock, who's a brilliant scientist, gives us a really, really good analogy to think about. So there are 2 types of smoking cessation programs out there. If you walk around major university campuses like the University of Chicago or University of Illinois at Chicago, you'll see little brochures from time to time that say smoking cessation study, looking for participants. And you can imagine the kind of people that call that number, pull down that little tag and show up every single week. These are the most highly motivated smokers. And these programs, these group programs, have excellent quit rates. In fact, the quit rates are 30 to 40%, which is really quite high for smoking cessation. On the other hand, the other approach that you can have is one that is more primary care oriented, in which case, as a physician, I just tell my smoking patients, I want you to stop. Here's a brochure, read it, come back and talk to me next time. Spend about 15 seconds. Is that going to be terribly effective? Not really. But what if we all did that? Not only physicians, what if every single nurse did that? What if every single teacher did that? What if every single community advocate or anyone else actually proceeded in the same way? Collectively, we would have a much, much, much larger effect on public health. So let's take that analogy and translate it to the issue of childhood obesity. So what contributes to childhood obesity? Smoking cessation. People often ask me, why is it that smoking rates have come down and we seem to have a pretty good handle on the problem, with some exceptions. And we're having so much trouble with obesity. And the answer is that smoking is basically a single behavior. You go into a store, you buy your cigarettes, you start smoking, and you suffer the ill health effects. You have to eat, you don't have to smoke. And obesity is much more complex and deals with the interaction between an individual, their genetic makeup, and the obesogenic environment in which we live. So, with that starting point, what are the behaviors that contribute the most? If I threw that question out to a group of people, and I've done that many times, and I'm not going to do it today in the interest of time, you get all kinds of interesting answers. So, I was speaking in San Francisco a few years ago to a group of the general public, and I asked the question, why do you think there are so many overweight and obese children today compared to 20, 30 years ago? And this lady stood up very, very confidently and said, it's all the homework. And I said, can you elaborate? She said, well, children have so much homework to do, they don't have time to go out and play, and they're becoming overweight. And I didn't dismiss it. I said, you might be right. But is that really where the biggest bang for the buck is? I mean, should we really cut down on homework? What are the behaviors that contribute the most? And furthermore, what's the evidence for each of those behaviors? So the Big Five is a concept that is adopted from, has anyone been on safari in Africa? A few people. I have not, personally. But if you go to Africa, to South Africa, for example, or Kenya, and you go on safari, there are 5 big animals you're expected to see if you really want to have a fulfilling vacation. And they are, I forget them sometimes, the leopard, the water buffalo for some reason, the elephant, the rhinoceros, and the hippopotamus. There's a North American Big Five that consists of the grizzly bear, the wolf, the American bison, I can't remember the other 2, and I'm sorry, mountain lion and something else. And if you've seen those, you haven't seen everything, but you've seen the highlights of what goes on. Similarly, with respect to childhood obesity, if everyone practiced good behaviors with respect to the Big Five, we'd still have obese people around, but there would be a lot fewer of them. And we could focus our remaining resources on those individuals that still need help. So the Big Five are, number 1, the frequency of fast food consumption. And notice how I worded that. It doesn't matter if you get the healthy salad meal at McDonald's, this applies to children, or the Big Mac meal. Once a child enters a fast food restaurant, it is a gray zone. We don't know what goes on. They may be stealing French fries from someone else's plate. It's the act of going that's associated with obesity. And the recommendation from the American Obesity Association is no more than once a week. I prefer, of course, 0. It is the number of hours of screen time a child is involved in a single day. Notice I use the word screen time. If you ask a 15-year-old boy, do you watch a lot of TV? I'm pretty sure the answer is going to be no, because there's not a lot on TV these days for 15-year-old boys. When I was a kid, we had the A-Team and Magnum PI, the Fall Guy, things that are long gone. The girls have these vampire shows and other things that they can watch. But the boys don't. So what do boys do? They play video games, or they go on the computer. And of course, you have to ask about that. And more recently, of course, it's the iPad and cell phones and texting, that sort of thing. How much of that sedentary screen time or media time does a child have? It's the total volume of sweet drinks consumed per day. And I want to be as inclusive as possible when I say that. There are, I believe, 9 categories of sweet drinks, and like the Big Five animals, I sometimes forget them. There's regular soda pop, flavored milk, fruit juices, fruit punch, energy drinks, regular sweetened iced tea, milkshakes, and a few other things. How do you ask that question? I'm not going to sit there and say, do you drink pop? And if I've got a 300-pound child and they say no, just move on. The way I ask the question is, do you drink anything besides water? If so, what is it? Tell me what you had yesterday. It was not water. A lot of these kids don't drink any water at all, so that should give you a good response. It's the total number of minutes of habitual physical activity. So that's the 4th component here that a child has per day. So habitual physical activity means it doesn't necessarily need to be an organized sport. So people are under the impression that you need to get the kids into the SUV, drive them to a soccer game, watch them play or not play for 30 or 40 minutes, and that you've done something great. It includes things such as walking and riding a bike, or just playing recreationally in similar activities. Unfortunately, that type of play has decreased markedly over the last 10 to 15 years. And the last component of the big five, does anyone have an idea what that might be? Family meals, yes. So it's kind of shocking that only 16% of American adolescents sit down to dinner with their parents every night, which is hard for people who are middle class or upper middle class folks to understand, because most of us did do that. But what's recommended is at least 5 to 7 times per night. And the mechanisms through which that controls obesity are not clear at all. Perhaps it's as simple as a family that eats together is probably preparing healthier meals, has more education, and is more conscious of nutrition. And perhaps there is an element of a limited amount of choices that are available to a child, healthier choices are available, but nevertheless it's certainly something that's good to promote. Here's how you can ask these questions. Do you eat regular fast food more than once per week? Do you consume more than one serving of sweet beverage? And there's many different categories, as I pointed out. Do you participate in a minimum of 30 minutes of physical activity per day? I was on the American Medical Association's expert committee on child and adolescent obesity, and you'll notice in their recommendations document that the recommended amount is 60 minutes per day. And when you're part of a committee, you just vote, and I voted against the 60-minute recommendation, simply because I felt that if you're starting from zero, to recommend 60 minutes might be a little bit intimidating for a lot of families, and it might be easier to start at least with 30 minutes, but that's just a matter of opinion. Do you eat dinner together with at least one parent on most days of the week? Do you watch television, play video games, or use a computer other than for schoolwork for more than 2 hours a day? So, here are some best practices. You asked the question, as I said, with respect to beverages. Do you drink anything besides water? If so, what and how much today and yesterday, to get an idea of their intake. And I know that you can't see this terribly well, but the Big Five scoring sheet is in your folders as well. I would also suggest that you go to our this website that we created at very large expense at the University of Pittsburgh, which is free to use by anybody, anywhere. And it is a tracker that uses visual aids to actually add meals to a plate. So how do I put the context of those behaviors into something I can do in the context of my busy clinical practice? Maybe not your clinical practice, your busy classroom or some other environment. The 5 A's paradigm is certainly not mine. It was invented by the National Cancer Institute specifically for smoking cessation. And it's a paradigm to carry out smoking cessation counseling in a really busy environment. So I told you about those intensive group approaches where there's a lot of, why do I smoke, what are the triggers, etc., how can I get you to stop? That is very, very expensive to deliver and requires a lot of specialized expertise. And then the 5 A's paradigm was simple. So with respect to smoking, you simply ask someone if they smoke, advise them to quit, agree upon a plan to quit, provide assistance, and arrange for follow-up. Let's now translate this to the issue of childhood obesity using a case scenario. So even before we get to this point, one question that often comes up when I'm speaking to physicians is, how do you even raise the issue of weight with a child and a family? Or if you're a teacher or somebody else who's involved in healthcare that has this responsibility, that cares about this issue, how do you raise the issue? When I was director of a pediatric obesity center, I never had that issue because their kids were coming there and they knew they were overweight, right? That's why they were coming to a place that says Weight Management and Wellness Center. It's not an asthma clinic. And so that challenge was something I didn't face. And so what I did is I looked into, there's no evidence on how to discuss this. The American Heart Association statement that I led in 2011, called New and Emerging Weight Management Strategies for Busy Ambulatory Settings, discusses strategies of discussing weight with adults, but not with children. So there is really no best practice. However, based on what primary care physicians tell me, these are family physicians and primary care pediatricians, there are some certain things that work better than others. First of all, start with the BMI. The BMI is a source of confusion for both children and adults, patients, and unfortunately some physicians as well. But that's actually a good thing. You can start the discussion by saying, your son's BMI is above the 95th percentile. I'm pretty sure the next question you're going to get is, well, was that good? Is that bad? What does it mean? Then pull out the growth chart and say, well, this is where they are with respect to other children. This puts, and then immediately switch the conversation to the health consequences of obesity. Talk about, this puts your child, Greg, at increased risk of diabetes, high blood pressure, obstructive sleep apnea, etc., whichever ones you choose to use. And then ask the question, is this something that concerns you? Is this something that you would like to work on with me? Notice I did not use the word obese. I didn't say Greg needs to lose weight. I certainly wouldn't use the word fat in that context. And I've asked the question in a way that is so gentle that it makes a parent and a child it makes it difficult for them to say no. Is this something concerns you, and is it something you'd like to work on with me? So that's what I would recommend in terms of raising the issue. Now, with respect to the big five, here's how we would do it. So Greg's a 13-year-old obese boy who drinks a minimum of 2 liters of soft drinks a day, not a surprising amount. Spends endless hours playing video games on his computer, completely sedentary, rarely eats fast food, so he has some good behaviors. Has dinner with his family every night. Comes to see you accompanied by his mother, Dawn, for a checkup of his asthma. He's recently recovered from an asthma exacerbation and is doing well. So you've got a few minutes left to discuss this issue. So Greg, by asking you a few questions, I picked up that there are some behaviors that you need to change to achieve a healthier weight and to prevent gaining too much weight in the future. Are you interested in working on making changes over a period of time? Dawn is his mother. Are you interested in working on this with Greg and with me? A very, very gentle way of asking the question. Are you interested in losing weight? Don't you want to be thin so girls will like you? Not the kinds of things you want to discuss at this point. So the advised part, so you've asked about behaviors. The advised part is you can give him concrete advice about what he's doing that is promoting obesity. So there are many different causes of obesity. In your case, there are at least 3 important things you need to work on. First, the amount of soft drinks you are consuming is a big part of the problem. And it's surprising the level of knowledge that's out there with respect to soft drinks and obesity, especially among people from poor families. So where I worked, a lot of poor families believed that if you drank a clear soft drink like Sprite, it was healthier than the colas and didn't contribute to obesity. Second, it sounds like you don't get any regular physical activity. This can be simple things like walking or riding a bike. Finally, the amount of time you spent playing video games is a problem. Spending less time would help him be more physically active and achieve a healthier weight. So here's your agreement, and of course this would take place over several more minutes, not as quickly as it's presented here. So let's work on changing some of these behaviors, Greg. Do you think you could cut down from 2 large bottles of soft drinks to 2 regular cans? Notice I haven't asked him to quit. You think about why so many people fail at diets. You know, you're eating a certain way your whole life, and then someone says, I'm starting the Atkins diet tomorrow. Everything changes all at once rather than incremental behavior change. I haven't asked him to quit. I'd like you to try to do this. Try water instead of soft drinks wherever you can. Also, do you think you could take a walk for 10 minutes every day after school? I'm not asking him to join an aerobics class. He's not going to do that anyway. But a 10-minute walk every day. That's all I'm going to ask him to do. He's got other unhealthy behaviors, undoubtedly. But this is a starting point in terms of our written agreement. We can provide him with some assistance. Of course, this is simplified, giving him alternatives. Have you tried low-fat milk? This might be worth trying. That's just a simple form of assistance. You can give him more sophisticated forms in terms of handouts, etc., that might be available to you. And you finally arrange for follow-up. So let's say that Greg has been able to cut out much of the soda from his diet. You start by saying, Greg, I think it's wonderful that you've cut out so much soda from your diet. It's great that you've lost weight, which he would have, as Dr. Ludwig pointed out. You told me the walking didn't go very well. Are you willing to try again? Let's try and find out why walking has been hard. Maybe another activity might be better for you. Never chastise a patient, especially a child, for failing to reach some sort of behavioral goal. Find out what the problem was and keep trying. It's the same with smoking cessation, of course. It takes about approximately 7 attempts to actually quit smoking for good. The advantage of this sort of 5 A's approach is it's relatively simple, can be carried out by anyone, even a parent. It doesn't take up much time. It focuses on healthy behaviors for a lifetime. It's flexible, so where I was speaking in California, which had the audience I was speaking to were physicians who cared for a large number of patients of Mexican-American origin, and they had specific challenges with respect to behaviors in that community. Fruit juice, for example, was considered to be a very healthy beverage, and a lot of young children were consuming these in large amounts. So you can actually modify the Big Five, or whatever it is, to the behaviors that are most common in your community. You can reinforce this over time. But here's the most important part. It does not stigmatize overweight and obese children. So if you have a thin child who is drinking 2 liters of soda pop a day, they're going to become obese anyway. But they're going to get a poor score with respect to the Big Five. And if that thin child's brother is doing the same sort of thing, they're also going to get the same feedback as well. What some people advocate is that we take the most obese children and we concentrate our best efforts on them. If you're a little less overweight, we concentrate less effort on you. And if you're healthy, we say congratulations, be on your way. I think that approach is going to fail simply because it puts an enormous amount of stigma upon children who are already feeling very, very stigmatized. So one thing we did not have a chance to discuss today was the psychosocial impact of obesity, which is extremely profound. If you focus only on the behavior and take the weight out of the equation, the weight will take care of itself eventually. Thank you very much.